So I have no disclosures. So here's a 91-year-old female with severe symptomatic aortic stenosis. Severe EF is 60% and TTE showed severe AS. And STS risk mortality is 6.5. And patient was evaluated by heart team and recommended transfemoral TAVR. And the Evolute 26 FX was planned via right percutaneous femoral arterial access with the sentinel cerebral embolic protection device at our center. As you can see, the FX has clear markers on the frame so that it helps you to place exactly at the lower part of the pigtail, which is very nice to see that these markers help us. And so then slow, obviously, release. And we do now pace at 180 once it makes an annular contact rather than slow pacing at 120. So anyhow, this patient, the next picture is here, aortography following valve deployment and valve embolized to the ascending aorta. So here, what should you do? So this is the main question that we have, right? So there are certain things that can be done. One is just go ahead and put in another valve through that valve. And so that was done, deployment of its second 26 millimeter Evolute FX valve. So it is not easy to advance sometimes through this valve system. So we'll talk about that. And you also see that there are coronaries that are here, and the valve frame, the first valve frame is right there. So that's maybe an issue as well. So those are some things that we'll talk about. But this patient, what immediately that next picture showed is that there's a second valve was deployed, and this is the picture that you see. So there is a huge amount of ascending aortic dissection that has happened in this patient, and what to do now. So echo, obviously TEE was done, and it shows a second valve deployment. Following the second valve deployment, there is very minimal AI or a trace, trivial. And so suprasternal images showing no evidence of aortic dissection propagation. So you can call the vascular surgeons, which I did as well, and nobody is going to take this patient for emergency surgery. So this patient, inpatient admission was complicated by ischemic stroke. Even though sentinel was used, it has happened a little bit later, managed conservatively with initial improvement in motor function. Repeat CT aortogram demonstrated localized aortic dissection without any propagation. But the patient developed acute kidney injury and with fluid overloaded. Patient finally died after 8 days by stopping. Patient was made comfort care, and patient died after 5 days at the request of the family. So that's a complication that can happen with the valve pop out. And so here is another patient. As you can see, during deployment, core valve popped out and ended up high. So this is what we normally come across, and this patient has a coronary graft here, as you can see. And so the right coronary artery is filling from here. So there are coronaries that we need to protect. And my talk is about when it pops out, where to keep it. Okay. So this patient, the second valve was placed lower with a good result, and the ECG and echo reveal normal conduction and normal LV function. And so that 1 hour later, patient develops chest pain and ST elevations, and the patient was brought back to the cath lab, and aortogram reveals no flow into coronary sinuses. And placement of second core valve inside first one created a tube graft like this, and obviously covered the right coronary artery. And so as you can see here, attempts to engage the right coronary artery was not successful. The vein graft is still protected by the prior bypass graft. So in this patient, so that's a good flow through the coronary bypass. So the lesson learned is unless STJ in the sinotubular junction and sinuses are enormous, pull first core valve into ascending aorta before deploying the second valve. Even if you think sinuses are large enough, consider pulling device into the ascending aorta. And so this is not the type of valve where you should be pulling it into the descending aorta. I think you can do that with the SAPIEN valve. I never had actually a SAPIEN valve pop out into the aorta, and only one of my patients had a pop in, meaning it went into the left ventricle. And so that actually can also be very dangerous because it can flip back and get into the aortic valve and occlude aorta and patient can die. That has happened to one of my friends. So if it pops into the left ventricle, obviously there's nothing that you can do other than actually calling a cardiac surgeon and open up the chest. And if it pops out into the aorta, you can pull it back into the descending aorta and deploy it anywhere below the left subclavian and above the renal arteries. So why does valve pop out? Not enough calcium, there is tension in the delivery system, and not centralizing the nose cone as on PVC, and I'll show you a picture of failure of pacemaker capture, and pulling on the delivery system before releasing all the tabs. Okay, so these are all the reasons that can happen, that can cause a valve pop out in self-expanding valves. If in a balloon expandable valve, the only reason that it will pop out is that there's no calcium and you undersize the valve. So please look at the valve size carefully on the CT scan, and I know that we don't want to oversize more than 20% that is associated with annular rupture, but at the same time you don't want to undersize too much that can actually cause a valve pop out. So here the nose cone is not centralized. One picture that actually shows that number one, the nose cone is not centralized. How do you centralize the nose cone? By just pulling back the wire into the nose cone, you can centralize it. The next most important thing is to make sure that the tabs are all released. It looks like that one tab may be attached. And if you pull it out at this point of time, obviously the valve is going to come back into the aorta. And so then post-dilatation is a risk for valve displacement. So whenever I do self-expanding valves, I always try to pre-dilate as much as possible, and we have our own algorithm. Anyone with calcium score of more than 2,000, a valve area less than 0.6, and all bicuspid valves, all 34 millimeter evolutes, we actually pre-dilate very good, very well. So in case if you are stuck with the high gradients and you have to post-dilate, be very careful. And the post-dilation with a previously used balloon was attempted here, and it caused downward shift of the second valve into the left ventricle during balloon positioning. So it's probably better to take a new valve, new balloon, and use it for post-dilation. Even then, when you're post-dilating, make sure that your pacing is good, your capture is good, and only then actually inflate on the balloon. So where to park the valve? As I said, just above the coronaries in patent native vessels. So you have to get another access. So if you use two femorals, get a radial access, put a snare through that, and you have to gooseneck snare the tab on the self-expanding valves and gently pull it up into the aorta, above the coronaries. If you put too much pressure on the snare, it can cause aortic dissection. So this is a risk that we all have done. I actually also had a dissection like that, so be careful. And just below the graft origins of all great vessels, that's where you have to park. And in a native vessel occlusion, where one of my patients had complete occlusion of all the coronaries and living off all the Lima to LAD and vein grafts, there is no need to worry about in that patient about native coronary artery flow. You just actually put in a second valve. So putting in a second valve through the first valve is also not very easy. Sometimes you have to create a rail. And so the risk of snaring or aortic dissection and risk of not snaring or coronary obstruction. So sometimes we have to snare the left ventricular wire to create a rail, and only then you'll be able to advance the second valve comfortably through the first valve. So valve calcium fixates the TAVR valve. We have to make sure that there is enough calcium, and I think Dr. Makker spoke about earlier about general valves. So special valves can be used for AI. Maybe that's what you can use in people without much of calcium. Rapid pacing in challenging cases needs to be done. I think usually self-expanding valves, we go to 120, we can go up to 180, making sure the mean arterial pressure is less than 40 or low. And the same thing should be applied even for balloon expandable valves, and we pace usually at 180 for both of them, or sometimes very rarely 200. More difficult to position the second valve. So this is very careful, think about it, and maybe if you are not well versed with it, it's probably best to leave it there and ask the surgeon to fix the valve. So what do you need? I think in mind, as sharp as Einstein, but I am Einstein because I think that's the only man who has a lot of IQ and fingers of a lady and heart of a lion. And if all else fails, maybe an extra pair of underwear. Okay. Thank you very much.